The traditional features of infantile Pompe, a historical cohort, would have died really by the age of 12 months or so, and certainly the pivotal trials run principally by Priya Krishnani out in Duke here showed a profound improvement of that. In fact, in the initial trial, all of the patients were living by 2 years of age. That it has subsequently become apparent that there is still great problems with the musculoskeletal point of view, and also from an enzyme point of view, that there is an immunological component that for some patients will interfere with interfere with enzyme efficacy through the production of antibodies. And so the infantile population has been divided up into CRIM positive and CRIM negative on their likelihood in producing antibodies. So we had a CRIM negative patient who, from a known family, who had whose previous children had died at sort of 7 or 8 months despite enzyme replacement therapy, having generated vast amount of antibodies. This child was born slightly prematurely at 33 weeks, was diagnosed, and we immunomodulated as with the classical protocol for immunomodulation at 35 weeks. And for the first 3 years of life, really did extremely well. Never produced any antibodies. Was walking at 16 months. Had minimal cardiac involvement, and really was a sort of, at the time, a example of a very good outcome from an infantile Pompe perspective. Sadly, at about 3.5 years of age, was noted to starting to have a degree of what appeared to be foot drop in the right foot. Now, there are different thoughts about dosing in infantile Pompes. It's one of the conditions where a lot more enzyme has had to be used because the uptake into the muscular compartment has been relatively low. And there's always been a question about actual titrating of dosage towards peripheral musculature. And so our initial response was this a sign that we were getting a degree of peripheral muscular weakness through underdosing. The things against that slightly were that it was distal. Mainly muscle weakness tends to be proximal and then spreads distal if it's just purely muscular in origin. And two, there seems to be an element of spasticity. Now, given the fact that we'd immunomodulated at at a time, which very early in life, there was a question of whether the immunomodulatory or the prematurity had caused some central defect. So we did an MRI. The MRI showed a degree of leukodystrophy, with the left side slightly more predominant, as would be fitting with a right-sided weakness. So we were unsure whether this was an aspect of the prematurity, the aspect of our immunomodulation, or something different. So we did a series of investigations to rule out any other inherited disease that we could treat, which sadly didn't give us very much apart from a slightly low CSF folate, which is often a marker of neurological stress rather than an inherited disease per se. But after about six months, we saw evolution to both ankles being involved, and that very much fitted with the evolution of the central imaging, where there had been an extension of the leukodystrophy. So I think that from an infantile Pompe's cohort, the Dutch experience, which was started being written up in 2016, I think there is some further work due to come out of Hans van der Kloog's group in Holland, would suggest that some of their infantile cohort had developed a leukodystrophy, and it seemed to be quite a lot older than our patients. So again, didn't quite fit. So we undertook sort of genomic examination of the things that we knew that potentially would cause a leukodystrophy, and thus far, despite us looking at good sort of 150 or plus candidate genes for leukodystrophy, we haven't found another cause. And I think that given all the work and given the knowledge that we've got from the sort of neurological involvement, particularly the work of sort of Barry Byrne down in Florida, there does seem in some patients, sadly, to be the possibility that this is now a new evolving phenotype, which in the infantile group we never saw before, mainly because they didn't live long enough to develop this. So I think we need to be quite careful. I don't know how I don't want to put about the idea that this is going to happen to every infantile patient. I don't think that's true, but I do think that if there is evolving peripheral, particularly distal symptomology in infantile Pompe patients, then I think we do need to have a think about whether it's a central origin or whether it's peripheral or not, because it very much will make an effect on how you go about potentially treating that.